Good evening, ladies and gentlemen, and welcome to PCR Studios in Paris. My name is Darren Milet, and I'm very delighted to be with you for the next 60 minutes for this PCR webinar entitled Cerebral Embolic Protection During TAVI, Evidence Meets Practice. Over the next hour, we hope to discuss with you the incidence and impact of TAVI-associated stroke, to review the mechanisms of those same strokes, to share with you some tips and tricks of potentially reducing the risk of stroke in TAVI, and of course to discuss the evidence for cerebral embolic protection devices, the evidence to date, and hopefully that's coming down the line. I would be very happy if you would submit to us your questions. You can do that via the chat, and we'll try and get to as many of those as possible. To share this topic with me, I've got two experts in the field, Dr. Christopher Cook from Essex, and Professor Rakesh Kharbanda from Oxford, both from the United Kingdom. Welcome, gentlemen, to Paris. And maybe we could kick off with you, Raj. So tell us a little bit about the incidence of stroke in TAVI. Has it declined? What are you seeing in your day-to-day clinical practice?
Yeah, so I think this slide really illustrates the strokes that have been reported in recent trials. I think trials are one way of looking, but also clinical real-world practice is reported in national registries, and certainly the current stroke rate is somewhere between 2 and 3%. Our own stroke rate in Oxford runs at 2.2% currently, and that's very much in keeping with the national UK data.
That's pretty much what we see. Chris, in Essex, are you seeing something different in terms of local stroke rates?
No, we're not seeing anything different to that. In fact, numerically, it's almost identical. So we're at 2.4%. So as you say, it seems that this is about the inherent stroke rate that is associated with a contemporary TAVI procedure.
What about the impact of stroke, Raj? Both on the patient, their families, the healthcare service?
Yeah, I mean, stroke's devastating, and disabling stroke, which is about half of the strokes that we see, is clearly a huge impact in terms of not returning home, often needing care home, rehabilitation. We know that there's an increase in mortality in 30 days and 12 months, six-fold increase. So it's a pretty devastating event in those regards. Even minor strokes, even less medically large strokes, however, have a huge impact, both in terms of returning to independence. You know, many of these patients are elderly. It's about returning that quality of life to them, and for them, stroke is reported as more devastating than other complications. So, you know, people really don't want stroke, and when it happens, not only does it have a bad impact on immediate outcomes, but it has impacts on families and on cost. So healthcare costs, we know, are hugely increased if a patient has a stroke.
It also seems to impact, certainly in our unit, quite badly the individuals in the cath lab. The team in the cath lab, when a stroke occurs, it's almost like a mortality. It certainly puts a downer on the whole team, and then of course the CCU and so forth. Chris, what about silent infarcts? We hear a lot about silent infarcts, that every TAVI procedure has some hits if you do MRI scans. Tell us what you understand by these silent infarcts and the impact that they could potentially have on patients.
Well, I guess the quick answer to that, Darren, is I don't fully understand what that impact is. As you rightly said, you know, if you do MRI brains on the majority of these patients, there are lots of microembolic events that happen during a TAVI procedure. And then really there's sort of two schools of thought. There's one that think that these may be a causative factor for dementia or cognitive decline, which is, you know, an alarming consideration, particularly as we might think about moving down into those younger, lower risk patients. But the complete opposite opinion also exists, which is that the TAVI has improved the hemodynamic situation, increased cerebral blood flow, you know, it could be neuroprotective. So when you have these two groups of opinions, I don't know what the correct answer is. What I do know is that we probably need to find out more about it, but it is inherently going to be very difficult to create these types of clinical trials that allow you to tease out what is going to be a subtle biological signal.
Yeah, and often we know if we do MRI studies on patients immediately in the aftermath of a TAVI, even those that haven't had a clinically apparent stroke, we see multiple hits. and those often dissipate over the next number of months. So whether they're truly associated with a cognitive decline is difficult to tell, but I suppose most of us here wouldn't like to have evidence of that imprint on our brains. Chris, what about the timing of stroke? Are most strokes around the time of the TAVI procedure or in the subsequent days or weeks?
It's a really important question. You know, it's not just the diagnosis of stroke, it's about when did that stroke occur. So before we go into the exact timings, I think it's important for people at home to understand that there are clear definitions about the timings of stroke around TAVI. These are the VARC definitions, which are useful for studies and defining their endpoints. But what you have on the screen now is I think, a really useful and informative slide. So I'll take you through this step by step. One of the first things you see highlighted in green here is that approximately 50% of the strokes that occur on that first day of the TAVI. And so I think most of us would consider that these are directly procedurally related. If we then look at the blue now, we say, well, actually, there's a significant group of patients, almost about the same, that actually have a stroke at day 1 to day 3. Now, classically, we may interpret these as different populations, or at least different etiologies of the stroke. But actually, something that I think is very interesting to think about is whether or not these later strokes, day 1 to day 3, are actually still procedural. And that what we're seeing is the clinical evolution of that procedural stroke.
Yeah, Raj, we spoke about this before we came live, and you have a particular opinion that many of these stroke events that become apparent on day 1 or day 2 post-TAVI may actually have their grounding or their formation around the time of the procedure. Can you tell us or explain to the viewers a little about that?
Yeah, so I think it's very difficult to know the exact mechanism, but we know that you get a shower of emboli, and the clinical manifestations of those emboli may manifest as very acute stroke early on, but actually those may form a nidus, a focus for thrombus formation in the subsequent few days. You may get edema around infarcts that may then manifest as later neurology. And sometimes the neurology is more diffuse. So confusion, delirium, that persists. Remember, the definition of stroke is persisting neurological defect. And if you've got a persisting confusion, depending on which areas of the brain are infarcted, the clinical manifestations can be quite varied. So I think we have to understand that the procedure, the big strokes that come very early on, at the day 0, day 1, are often very easy to recognize. But some of these more subtle neurology may not manifest clinically, but may be procedure related and therefore embolic, or therefore interventions may have a role in preventing them.
That's brilliant. Thanks, Raj. Chris, what about the mechanisms of stroke? What are our understanding about the variety of different mechanisms that could cause a stroke during or around the time of a procedure?
Okay, so for me, you know, the way I like to think about this is really one of 3 major groups. So if we think about it, the first group that we need to consider is whether or not these are hemorrhagic in origin. And we have to think about what we're doing in TAVI. Ultimately, we are heparinizing these patients, often with activated clotting times greater than 300. So, you know, there is certainly the basis for hemorrhagic etiology of stroke, but it's my personal experience, and I'm sure probably yours, that fortunately, the minority of strokes we see are actually hemorrhagic. So this brings us on to the second group of patients, which is that sort of global ischemic hit that you might get at certain stages during the TAVI procedure. You know, I do worry about this, those patients who have a degree of vascular disease, and then at certain points when we're rapid pacing, for example, where you have drops in blood pressure and hypotension, you may end up with these watershed infarcts, these global ischemic insults. But really, I think the key group that we need to explore and dive a little bit deeper on is the embolic phenomenon. And really, you know, as TAVI operators and those of you at home who are watching, we can see that clearly at multiple points within a TAVI procedure. There are potential areas where we can result in thromboembolic debris going up to the brain. For example, the use of stiff guide wires crossing often heavily calcified arches with large pieces of equipment, the performing of balloon aortic valvuloplasty or deploying or manipulating that valve at the annulus. And even when the valve is in and we think the case is almost completed, actually, atrial arrhythmias, changes in protamine, these sorts of things are also foci for potential thromboembolic phenomenon.
Raj, I suppose Chris has talked us through the various elements in a TAVI procedure. From your experience, or what's your sense of what is the point at which during the TAVI procedure we have the greatest risk of causing stroke? Is it transitioning the arch? Is it implanting the valve? Is it the predilatation that certainly in our early TAVI experience we used to blame?
Yeah, I mean, I think, TAVI's got better, and we've got better at doing it, and the equipment's got better. But I think manipulating around the arch where clearly, depending upon how much disease there is, the emboli can go straight up into the cerebral vessels, manipulating the valve and either pre or post dilatation, we know. So I think it's about the amount of manipulation in the proximal aorta and the arch. Those are the key aspects of where you're going to generate embolic debris.
Okay. So if we understand then the mechanisms, be that global ischemia, be it embolic, and we understand the things that cause those emboli, surely then, Raj, we can predict which patients are going to have a stroke and target our interventions at those patients.
Yeah, that's the holy grail, isn't it? To be able to sit in and say, this is your stroke risk, this is the predicted risk. So the slide that we're just about to see is a rather artificial forest plot, and it looks at a number of clinical risk factors. You can see there's age, there's gender, there's prior TIA, stroke, bicuspid valve anatomy, atrial fibrillation, renal failure. So these have all been picked out in a slew of studies and show an association with an increased stroke risk. But if you look at trying to develop a scoring system, and Vinod Thurani did this with the TVT registry, large number of patients, very sophisticated statistic modelling, try and pull out a risk score. Can we predict it? About 60% predictive value. So flick a coin. So ultimately, although we've got these good clinical handles, the actual stroke risk is unpredictable.
Chris, why do you think this is? I mean, if we understand the risk factors, why is stroke still so elusive in TAVI? And maybe, I suppose, the reason that we ask this is that if we have a certain amount of money in our institutions or a certain availability of a product, such as an embolic protection device, we tend to try and target that, I suppose, those devices at the patients who are at higher risk. Traditionally, they've been bicuspid valves, valve-in-valve procedures, patients with prior stroke. Why is it that we don't seem to be able to drill down and find those patients who are at highest risk?
Well, I think part of the issue is that it's not just the patient, is it? As you said, it's procedural aspects and patient aspects. So we're mixing together lots of variables. Where do you end? Is it one valve type versus another, etc.? Is it the anatomy? And of course, we make choices, and they're biased choices. When we choose to use one particular valve type, it's because of that interaction with the patient anatomy. So I think even though these individual factors that you showed on that forest plot have quite impressive odds ratios, that one would think, well, that must be a causative factor that you could model a risk score on. When you factor in all of the aspects that it takes to get a patient successfully treated with a TAVI, I think that's where these factors break down and we struggle to really predictably model it.
Okay. It comes down then, I suppose, to considering that those patient factors and indeed those procedural factors. But it would be interesting, I think, to understand the various choices that we make in a procedure and how they can impact an individual stroke risk. So, Chris, you've developed this slide with a number of potential choices that we have during a TAVI procedure. And maybe what I'll do is ask you to take us through the first one, for example, the access route. Are there different stroke rates or divergent stroke rates depending on the type of access that you have?
Yeah, well, I think, for those watching at home, I think one of the core messages to get across here is that the main clinical benefit of TAVI lies within the transfemoral route. And that is, of course, how the studies have been designed. And so if we are thinking about these contemporary TAVI trials, particularly in the lower risk patients with stroke rates of approximately 2%, they're all transfemoral. And if you start thinking then about alternate access type routes, such as, globally with the second most common being the axillary or subclavian route, there are some registry-based data out there that shows that perhaps there is double the event rate in terms of stroke for axillary versus transfemoral access.
Raj, those rates are quite concerning. Do you have a sense of why, apart from, of course, a higher risk patient group, why has the subclavian or axillary access been consistently associated with a slightly higher risk or a significantly higher risk of stroke?
Yeah, I mean, I want to reiterate that point. I think it is the patient. The fact that you can't do a femoral access tells you they've got pretty severe and advanced peripheral vascular disease. That's usually associated with carotid and cerebrovascular disease. So I think that's, we shouldn't underscore that. I think the techniques are also different. We haven't got dedicated technology. Transfemoral access has moved on. Our equipment is tailored to that. We're doing these non-transfemoral procedures with equipment that isn't designed for that. The procedures are longer. We aren't doing as many of them. There's the learning curve aspect. So I think there's a number of additive factors to why the outcomes aren't so good and the stroke rates may be higher. More manipulation of the devices, whichever device you use from an axillary approach, the manipulation in the ascending aorta is more than with a transfemoral approach.
Yeah, it is an interesting feature, though, that if we compare side by side the stroke rates with, for example, the carotid access versus the subclavian access, that we do see quite a difference in terms of stroke rates, 2 to 3% with carotids versus, 8 to 10% often with the subclavian. Of course, with the carotid, by having a large sheath in the left common carotid, you've blocked one of the major access routes to the brain. And of course, you've selected a patient group that have good carotid arteries by definition. So I think it is largely patient factors, but it certainly is interesting.
I wonder whether it's also the angle of approach. The manipulation is much more from the
left to right. Yeah. What about THV choice, Raj? This is a hot potato. I'm sorry to ask you about this one. But do we, again, we see, I'm not going to say do we see divergent stroke rates in different studies with different devices. Is that a factor?
Yeah, I mean, I think, again, I do think it's about the patient and why those valves have been selected. There are patient factors that might encourage you to use a particular valve type. So in complex anatomy with very heavy calcification, you might choose a self-expanding type platform to reduce the risk of rupture. And that may be associated with an increased risk of stroke in itself. So I think it's difficult to say it's the device. I suspect it's the patient for which that device is chosen. And there's also then the learning curve and why all of those aspects.
So again, that the integration of those patient and procedural factors that we've discussed right from the beginning. Chris, your slide, you've got attention to the arch, and again, we all worry about transitioning across calcified or angulated arches. Are there particular devices that you would use to navigate a hostile arch?
Yeah, and I think, the reason I included that particular point within that slide is first and foremost is to make sure that we're using all of the information that the TAVI CT scan gives us. it's quite easy to just focus on the transfemoral, common femorals and iliacs and think, okay, that's the analysis of the peripheries done. But certainly when we're training our fellows in their CT analysis, the first thing we ask them to do is start from the top and look at the arch, get an understanding of the angulations that are involved, what is the distribution of calcium or indeed plaque, and really that can begin to refine our strategies. That's point number one. Point number two was you asked, does that actually change what we do? Well, the answer is yes. So particularly angulated type anatomies, I'd be more inclined to select a device that either allows me to steer around that actively, so the balloon expandable platform, or the self-expanding platforms that I know have very, very good flexibility in multiple planes. Because really, when you're looking at these arches in details, they are complex 3D structures. And it's about understanding, will your prosthesis allow you to navigate that without excessive scraping of the outer wall, for example. And this isn't just for the primary operator, because the second operator has a really important role when they're helping that prosthesis to traverse the arch. And what I mean by that is applying appropriate negative tension on the wire to bring them off that outer aspect and hopefully make sure that, again, you're not interacting with any calcium or plaque disease in the arch.
Yeah, that's an important tip, that it's not just the device, but also the interplay of the device with the anatomy, and that can be mitigated somewhat by appropriate manipulation of the wire. Just to come back to our audience again and to reiterate that we will answer all of your questions if you want to get them in. I see that Samuel, Antonius and Rehal are online, so if you guys have any questions, please do pass them on to us. Raj, coming back to other procedural factors that we can use to mitigate stroke, an ACT greater than 300 standard in your practice, how often do you measure it during a TAVI procedure? When do you give the heparin?
Yeah, great. So we give it, we do use routine heparin, and we do target an ACT of 300. We give the heparin as soon as we have confident vascular access, so as the proglides are going in, before the big sheath goes in. And we give weight-adjusted heparin, and we measure the ACT 5 minutes after the heparin has gone in. So okay. That's usually sheath up, cross the valve before we get the valve in. That's usually, we like an ACT of above 300 at that point.
5 minutes, you guys are very quick. Very good. Chris, next one, hypotension and short rapid pacing runs. You spoke earlier about those potential watershed infarcts if you have swings in blood pressure. I presume that this speaks to that comment.
It does, exactly. So it's about trying to mitigate or limit the impact of these swings of blood pressure. Now, we had a fairly heated discussion offline about whether or not anaesthetists are an integral part of the contemporary TAVI team. I very much value my anaesthetic colleagues and are glad they are there. So that point for me particularly down is actually I'll let them know. I'll say, we're about to do a rapid pacing run here. This patient has a poor left ventricle. Would you mind, please, if needed, supporting that blood pressure as we come out of that rapid pacing run? So that's why I included it as a potential area of procedural optimization for that.
Okay. I think an important point just to clarify, I very much value the contribution of our anaesthetic colleagues at all stages of our procedures. But I personally, again, my experience is that when we've done procedures with anaesthetists, maybe those that are less familiar with the procedure, that we tend to get more sedated patients. We tend therefore to see patients who have greater swings in blood pressure. So maybe the experience of your heart team is such that you avoid those swings with anaesthetic agents.
Just one more thing to pick up perhaps on the rapid pacing element. So there's two things here. I've also moved towards rapid pacing at 200 beats per minute for the balloon aortic valvuloplasty, because sometimes, these are slightly undersized aortic balloons. And what I really, really feel unpleasant seeing is that balloon shifting up and down as you're performing the balloon aortic valvuloplasty. So in patients where we think they can tolerate it, we aim to actually pace at 200, and that really mitigates against that in terms of that potential embolic phenomenon that you might get from a prosthesis that's moving up and down at the leaflet tips or annulus level.
Okay, so less flossing of the valve is appropriate in Essex. Good. Raj, protamine reversal. We've seen some evidence from St. Thomas's Hospital in the UK regarding a neutral impact of that, be it on stroke or be it on bleeding. What do you guys do, and do you think that reversing the protamine could potentially impact stroke rates?
Yeah, so heparin reversal giving protamine. So protamine at high doses is prothrombotic, and that's part of the debate. And then the other debate, obviously, is do you actively reverse the anticoagulation on board? So, the evidence we've got is not designed for stroke. So I think let's keep it away from that. It's about the bleeding, and I think our own practice is to deliver protamine to reverse the heparin. But if the patient has had recent coronary intervention with fresh stents, for example, then we're much less aggressive with reversing the protamine, reversing the heparin. And if there's any concern, for example, about a dissection or slow flow, then again, we prefer the heparin to wear off itself. But I think the theoretical concern is you create a prothrombotic state by immediately reversing the heparin effect and additively the prothrombotic effect of protamine. And that may have a role, and I think particularly in patients, for example, with atrial fibrillation, where our practice now is to try not to stop their anticoagulant therapy for that time. But there are cases where it has been stopped, and I think there are cases where the patient factors may mean that you don't want to induce a prothrombotic state. Okay,
so a case-by-case basis, but when we spoke offline earlier, guys, I think all of us do a gentle reversal of protamine rather than a big whop to completely create that prothrombotic state. The last one that we see up there is the continuation of novel anticoagulants. We're involved in the popular PAUSE study, which randomizes patients to continuation of the DOAC versus discontinuation 3 days prior to the TAVI. And to date, I must say we haven't seen more bleeding events, but obviously the trial itself will report on whether that's associated with a reduction of stroke. And of course, this is in a particular patient population who are on oral anticoagulants for atrial fibrillation. So we await the results of that. I think it's important that we move on to the use of cerebral embolic protection devices, as the title of this webinar suggests. And the landscape for these devices has always been in flux. We see a number of devices that are in clinical trials. Some of these devices have disappeared over the years, some new ones coming online. And I would encourage you all to read this important state-of-the-art manuscript in your intervention. It's really an excellent read, a shameless advertisement for the journal there. But ultimately, Chris, our data revolves around the Sentinel device. And so you might kindly take us through the evidence that we've generated to date for this particular device. And I think it's important to contextualize that when we talk about the evidence for cerebral embolic protection, we're really discussing Sentinel at this point. And whether these findings remain true of other devices in due course, that has to be proven.
Absolutely, Darren. So you're quite right. So we're in the privileged position of getting to look back at the early Sentinel experience and seeing where this story of embolic protection evolved from. And so really that begins back in the relatively early days of TAVI here from 2016 with Nicholas Van Meegen and colleagues. And they did, I actually think, a really elegant small study where they took a population of 65 transfemoral TAVI patients and then they randomized these 1-to-1, those that received Sentinel protection and those that the control arm did not. They had a number of outcomes they were looking at. They looked at MRI brain imaging, they looked at neurocognition, but I think the one that's really interesting and that we'll focus on is looking at debris assessment. And then they performed this study over a period of approximately 2 years. And in the top right image there, you'll see some of the actual debris caught within the filters of the Sentinel device. And the first key finding here is that 100% of examined filter nets demonstrated debris. And on top of that, it wasn't just what you may think it would have been, such as purely calcium or purely fibrin. In fact, actually, there's a broad spectrum of materials that were captured within these embolic filtration devices. And we're talking including things like myocardium, foreign bodies, parts of the swabs, for example. So this is early study, but I think it's really important because it sort of sets the landscape, and it does suggest and prove, in fact, that the embolization paradigm is real as part of TAVI, and therefore it confirms biological plausibility of a device that's designed to catch this debris. And so ultimately, there is a potential therapeutic target here. So if we move on, the year after that, and I remember this being presented to much excitement from the community, we've actually got one of the biggest at the time randomized controlled trial, over 350 patients here. And again, simple design, randomized to cerebral embolic protection with the Sentinel versus none. Outcome in this study was brain MRI scanning. So this is, and we'll soon find out, underpowered for clinical events, but we do have an imaging surrogate here. And this was done critically between 2 to 7 days post-TAVI. And remember, we had a nice discussion about the timing of stroke being so crucial with regards to understanding its relationship to TAVI. Now here you see the primary study endpoint, which is actually a numerical decline in new lesions seen on MRI brain in those patients who had the Sentinel versus those did not. And although they're underpowered, they did also report the stroke rates. And I found it really interesting to read. You have 5.6% in the Sentinel group, plays 9.1% in the control group. So you see numerical differences, but actually none of these were statistically significant, and in fact, some way from it.
Chris, also interesting to note that in the Sentinel study, there was a safety arm, and that a third of those patients who received the Sentinel device were part of that arm. And one thing that remains consistent with this device is that it is safe, that we have not seen high numbers of vascular complications, we have not seen dissections, we have not seen higher stroke rates, we have not seen the development of thrombus in situ on these filters. And so as we evolve through the evidence, I think it's important to note that really what we're talking about is efficacy in stroke reduction. Because the Sentinel, I think, was the first study that had a randomized arm purely looking at safety and suggested that, again, these devices or this particular device is safe.
Yeah, and to your point, when you showed your slide of the very many potential devices out there, some of them had 16 French vascular access requirements. So we know that when we're talking about the Sentinel, we're talking about a safe device, which is from the right radial or brachial, 6 French, easy delivery. So you're right, we cannot attribute a class effect based on the data that I'm discussing with you now. Okay, and so let's just go to the third study that I wanted to bring to the group, which is, and you can see that we're beginning to go up the ladder of evidence, if you will. So this is a patient-level meta-analysis. Again, bringing together at this time the largest data set, including registry data, of over 1,000 patients, approximately 500 between Sentinel and control. And you can see here that the outcome here is actually now a clinical endpoint. So we're talking about procedural stroke, and particularly we're referencing the VARC2 criteria. Remember, we talked about how it's important to have clear definitions for clinical studies, and these are within that 72-hour window. Again, remember that we saw in that slide that this accounts for the vast majority of strokes which are related to the TAVI procedure. And here in this analysis, we did see an important treatment effect. with a 65% reduction in the occurrence of stroke in those patients who had cerebral embolic protection with the Sentinel device versus those that did not. And additionally, we also saw something we like to see in meta-analyses, which is that all of the directions are in favour of one particular intervention on the subgroup analysis.
Chris, I'd like to just pause here for a moment and talk a little bit about this observational data, because really all of the various data sets that came out, be it the Ulm group, be it from Rotterdam, the combination of that data, the TVT registry, all of these data sets have pointed towards a reduction in stroke rates that is quite considerable with the Sentinel device versus control. Why is it, do you think, that we saw such dramatic reduction in stroke rates with this? And of course, we're going to move on to the randomized trials in a few moments, but talk me through why you think these data are so compelling.
Well, I think the first and most important thing to say is always have a high index of suspicion when you're looking at observational data. If you truly want to understand what the intervention of a medical device is, then the best way to study that, and we will discuss that, is within randomized controlled settings. So anything observational to be includes a discussion around potential biases. And so those biases may be that actually they're using this device in particular anatomies that are potentially very high risk for stroke. That's one consideration. So you could be having cases where the calcium score is very high, or the particular procedure that you're doing, bicuspid or valve-in-valve. These are things that could potentially power, in an observational setting, a reason why you might have an exaggerated treatment effect.
Okay. And so the next level of evidence, obviously, that was required with respect to embolic protection was, of course, to take it on towards a randomized trial. And the protected TAVR trial was that study. This was a very important study published last year in the New England that compared a primary endpoint of stroke at 72 hours or discharge in patients undergoing TAVI with cerebral embolic protection as the test arm and TAVI without embolic protection as the control arm. The assumptions of this study was that the stroke rate would be approximately 4% in the control arm and reduced by 50% down to 2% with the embolic protection device. So those assumptions are very important to build into a trial. And when we look at the number of patients that are required to power that trial, they become absolutely crucial. One of the other important issues in this study is that there was neurological assessment before and after the TAVI procedure. And the reason to do that is to try and pick up small strokes that may not be apparent to interventional cardiologists who aren't stroke trained, such as most of us sitting at the table. So an important study with 3,000 patients. Now, most of us are aware of the results of this study, which are depicted in this slide. What we see is that the total stroke rate amongst patients who were protected with the Sentinel device was 2.3%, and the stroke rate amongst patients in the control group who did not receive the Sentinel device was 2.9%. So the absolute difference was 0.6%, and that was not statistically significant. Again, it's important to come back to the original assumptions of the study. It was expected that the control arm would have a stroke rate of 4.9%, and what they saw was 2.9%. That tells us that ultimately this study is an underpowered study to detect a meaningful difference in stroke. You'll also notice in these bars that there appears to be a difference in disabling stroke, and indeed there was a statistically significant difference in disabling stroke between the control arm and between those that received the cerebral embolic protection device with Sentinel. This was a secondary endpoint, it was non-powered, and therefore can only be adjudicated to be hypothesis generating. But ultimately, this study unfortunately for our community, suggested that the routine use of Sentinel device did not reduce the incidence of stroke. Raj, if I can come to you, why do you think that we saw lower rates of stroke in this trial than was predicted?
Yeah, I mean, I think everything was done to ascertain stroke. And I think it's about the potentially that this was, as you know, a trial recruiting in the United States and Europe where the device is routinely available. So I think it's something, or it may be something to do with what proportion of the eligible population were ultimately recruited. And in a system where you've got access to the device, the patients that were enrolled may either be low risk or patients who weren't going to get the device up front. So I think those subtleties are things that may explain the result. But the rates we're seeing are what is reflected now in contemporary practice.
Yeah, that was also what I was going to suggest, that the study was designed at a time when potentially stroke rates were that little bit higher before we as operators became more adept at doing these procedures. Chris, your take on that study?
So one thing I was in America at the conference at which this study was presented, and it was exactly as you presented your slide then, effectively a neutral trial. But it was so interesting that they went round the panel at the time and said, so based on what you know about the study, who would have cerebral embolic protection as part of their TAVI procedure? And rightly or wrongly, that question was asked, and unanimously everybody put their hand up. Now, that really gets to the point of just how serious a stroke is, particularly a disabling stroke, of course. So science is mixed up with emotion and psychology slightly here with the fact that stroke is such an important endpoint for a complication for TAVI.
But I think it also speaks to what you described earlier, the biologic plausibility of stroke in the setting of TAVI. That most of us believe that the strokes are caused by debris that comes off the valve or the arch, embolizes to the brain and causes a stroke syndrome. And most of us would believe that there must be devices that we can develop to reduce the impact of that debris shower in our brain. So I think it speaks to the severity of the stroke event, but also the biologic plausibility of these devices to reduce the impact of stroke. But ultimately, Raj, we're left with a study that doesn't answer the question. It doesn't tell us whether the Sentinel device reduces the risk of stroke in patients undergoing TAVI, or it doesn't tell us whether it does not. Of course, it's hypothesis generating, but the impact on those larger strokes, potentially that's a group that benefit from this. But what are you currently doing with your patients in 2023 to manage their stroke risk?
Yeah, that's where we are now, isn't it? And we don't know the answer. So I think, let's look at a case. So this is a real-world case, 77-year-old lady. She's had a complete heart block. She's had a TIA and a stroke. So she's in that high-risk group. She's got aortic stenosis and needs a TAVI procedure. And so when I see these patients in the clinic, I describe that risk. I say the risk of stroke is 2%, 1 in 50. And we're currently enrolling for the British Heart Foundation Protect TAVI trial. And I offer them participation in that trial by saying we don't know if the device works. But in the UK, you can't get the device outside the trial, which speaks to why it's good to run it in the UK. And we would offer enrollment in the trial.
And so the idea of having I suppose, speak to me a little bit about the impact of not having the device commercially available in the UK. What does that do in terms of the sample of patients that you're evaluating this device in?
Yeah. So look, I'll put up the sort of slide of the trial setup, if you like. So We are looking for 7,730 patients, which is about the annual volume of TAVI activity in the UK. We do about 7,000 procedures in the UK across 34 TAVI sites. The trial is designed differently to protected TAVR, which you've just heard. Our assumptions were a 3% event rate in the control group, a 33% effect size, meaning a reduction to 2% in the treatment group. And based on those assumptions, we need 7,730 patients, one-to-one randomization. We didn't have routine neurology. We have a questionnaire because it's a pragmatic clinical trial. We want to run this through quickly. We want to try and get patients in and ease the thing.
What kind of buy-in, Raj, again, have you had from the TAVI community in the UK? Because again, I'm interested to understand the level of risk that you're enrolling in of patients that you're enrolling in this trial, and how that may differ to the level of risk of those patients enrolled in protected TAVI.
So our largest sites have recruited, and Leeds and Dan Blackman and Brighton and us and other, key sites are recruiting approximately 60 to 70% of our eligible TAVI populations. All 34 sites in the UK are recruiting. And in terms of the look at how much of our national population is being recruited, we're recruiting 40% thereabouts of patients undergoing TAVI in the UK. So this is a representative population across the risk groups, including urgent and elective cases. This is, whereas if you looked at protected TAVR, of the eligible population, about 10% were enrolled. So this is a wider enrollment with a wider risk group.
So the applicability of these results is much wider, for example, than the more focused clinical trial group that we saw in protected TAVR, which is always the difficulty, is applying the results from a clinical trial to real-world practice, whereas you flipped it, and now you have the real-world practice in this clinical trial.
Yeah, I mean, that was the intention. Let's switch national practice with a device and see if we see an effect. So that's the intention. So turning back to our case, what do I look for when the patient is randomized to an embolic protection device, Sentinel? So we look at the CT, and I think the points you make, Chris, about leveraging all the information. We're looking at the right brachiocephalic, the left carotid. We're looking at the size of the vessels, the origin of those vessels, making sure it's not very angulated, and making sure there's no major disease. And this video now will show you the deployment of a device. So an aortogram, which we don't routinely do nowadays. We used to understand the anatomy, but with the CT and looking at that in detail, you can predict where it's going to be. The device itself has a very ergonomic handle that controls the proximal device and the distal filter. You can see here on the fluoroscopy now the deployment of the filter in the right brachiocephalic trunk. The device is then brought back and flexed, and you direct that toward the left carotid. You then pass a standard angioplasty wire into the left carotid. That acts as a rail. You pull the device back and then deliver the distal filter. So you can see that that's a very straightforward procedure. It takes a few minutes. And as you've already said, we know that this device is safe. So it's a safe device, and it's easily delivered. And that's the standard way that we would undertake this delivery in our practice.
I presume that you would remove the trapped pigtail there, Raj, before you proceed.
Yeah, that's a great point. So we don't, in fact, leave the pigtail now. And yes, I'll bring that back. But yes, the pigtail. And also the other thing to remember is when you've got the device in, as you bring your device around, you want to make sure that it doesn't interact with the Sentinel and dislocate it.
Raj, there's a question from Henrik Nissen who says, can you describe to us which patients aren't included? So, for example, you mentioned some centres where maybe 70% of patients are included. Others, it must be much lower if you've got a 40% inclusion from the UK. What patients do you think are not being included, or can you give us some reasons that patients are not included? Obviously, this trial started during COVID.
Yeah.
Having the trial infrastructure and the research nurses available in all centres is not always possible. What are your thoughts on?
So our trial inclusion and exclusion criteria the inclusion criteria are very, very broad, and basically, does the operators think they can deliver a Sentinel device? That's the inclusion criteria, i.e., do they have a palpable right-sided pulse in the limb? And it's as simple as that. And is the anatomy not prohibitive? So we've left it very much to the discretion of experienced operators to say, can you deliver a Sentinel device? The inclusion criteria for the trial are very pragmatic and clinical. The reasons that patients aren't recruited are, as you've said, trial infrastructure. And when I say 40%, not all those 34 sites came on board immediately. So there's been a gradual increase in the number of centres over that time. And if I show you that graph of trial activity, you can see we started this just as COVID hit us, but we were very lucky and we're ahead of recruitment, and we hope to complete recruitment for the 70% interim analysis by the end of this year. And the data monitoring committee will then tell us whether we should stop either because of futility or because of efficacy. And if we continue, then we should complete the trial by the end of 2024 or early 2025.
And when you look at that data, Raj, do you have the option to extend the sample size if the stroke rates are a little lower, as was seen, for example, in protected TAVR?
Yeah, so we will rely. It's not an adaptive design, so that's an important thing for those trialists out there. There's a price to be paid for an adaptive design, but if the stroke rates are low and the data monitoring committee don't see a benefit in us continuing, then we will have those discussions. But at the moment, I don't know, because the trial is blinded, so I can't answer that question.
That's okay. Chris, but before we move on, obviously you're involved in the study and clearly randomizing a lot of patients. But if you were sitting in Central Europe, if you were in the US, I think one of the questions that our viewers are going to have is, in whom do we use these devices? If you have 10 devices or 20 devices out of your next 50 TAVI patients, who would you be focusing on to use these devices in?
Yeah, so I think that might be where we end up as a community, is focusing on those that we think do have that high, thromboembolic stroke risk. So to that, what comes to mind for me are patients with very high calcium scores of the aortic valve, the valve-in-valve type patients, and also the bicuspid type patients as well. These are the sort of three main groups for me that make me think this could be someone who we may apply in a focused fashion the use of what is a limited potential resource.
Thanks, Chris. So in the situation where you're in the middle of a TAVI, you've crossed the arch, and unfortunately a stroke event has happened while you're in the process of implanting a valve. Raj, in your centre, what diagnostic algorithm do you have in place to manage that clinical stroke?
Yeah, so we work. So I work in a tertiary stroke unit, so I have access to very experienced stroke physicians and thrombectomy. But the algorithm really is a recognition of acute neurology. Don't dismiss acute neurology. 99% of patients wake up after the procedure and say thank you. If the patient doesn't wake up or they have residual neurology, suspect an event. You then undertake a CT scan of the brain and CT angiography. And the CT is to exclude hemorrhage, and the angiogram is to determine where the occlusion is. And often there might be more than one occlusion. And then it's really about understanding where the occlusion is, what treatments you might offer. And I've just put on this slide a very nice image, but this is the sort of advanced imaging that stroke units which experienced imaging can give you. So it can tell you about perfusion, it can tell you about infarction, it can tell you about penumbra, It can tell you about how much tissue there is left to salvage. And that's important in deciding the treatment. So if it's very proximal, then you might consider mechanical thrombectomy. If it's very distal or not suitable for thrombectomy, then it's a decision between the bleeding risk of thrombolysis and the amount of neurology that you're going to salvage and save. So in somebody with quite debilitating symptoms, you might have a lower threshold to consider thrombolysis, but with minor neurology, you might manage that conservatively.
And Raj, in terms of the thrombectomy option, I mean, our current devices, are they designed to deal with the embolic debris from TAVI?
No, exactly not. I mean, these devices are soft devices designed for soft thrombus. And, you know, when I go into the neurointervention suite and watch them do these procedures, the devices aren't designed for the lumps of calcium that are extracted. But remember, thrombolysis hasn't been tested in this setting either. And that, I think we're in an area where we really need to work to come to that judgment with the neurologists, understanding with stroke physicians, with the imaging, and do it on a case-by-case basis.
Chris, you and I don't work in centres where neurointervention is routinely available. How do you weigh up that decision between using a lytic in someone who's just had a TAVI and a large bore access, been heparinized, or being more cautious and not using that lytic? Because that's something that I've faced in my practice, and I struggle with that decision.
Yeah, I mean, I struggle similarly because it is a big decision. It's a big call. They're almost at opposite ends of the risk effect, really. One is going to directly impact the other. So I think, you know, one of the key messages we've tried to get across here is that really no TAVI procedure is the same between patients. So when we're thinking about what is our bleeding risk for thrombolizing this patient, we have to be aware of what the closure was like. Is there any small effusion at any point during the case? How confident are we that we could manage any bleeding complications were we to thrombolize the patient? And then from the neurological side of things, it is about how significant is that neurology, and is there that evolution happening as well? Ultimately, this is a decision that is shared. It's shared with the stroke physicians, and it's important to have that dialogue and communication. But I don't think there's any binary yes-no situations you would definitely do. I think you have to look at the patient and the case in all of its entirety.
It's a difficult one. Raj, before we close, we have a good question from Laura, who says, you know, we've got so many different TAVI devices. Soon we're going to have different embolic protection devices on the market. How do we tell the value between different devices and different embolic protection devices and the various mixes that we can use there? How do we weigh that up in an individual case to make the right decision for the patient on the table?
Yeah, that's a great question, Laura. I think what we're hoping for is, with more data, and we've actually got a pre-planned analysis with the Protected TAVR group, which will give us, 10,000 patients in a trial setting. I hope we can develop an adequate risk scoring system to allow us to tease out which patients might benefit. We might get some information from the different devices in that cohort. So I think it's about using the information that we have to inform our practice most effectively. So Laura, keep looking forward. I think in a couple of years we'll have some ways of answering that question better for you.
So hopefully the end of 2024, if not sooner, Raj. So with that, we're approaching the end of the webinar, and maybe to conclude, we've heard that stroke rates of 2 to 3% are what is expected in contemporary practice with contemporary devices. But despite these relatively modest rates, stroke remains a devastating impact for our patients, with 5 to 6 times the mortality, and of course all of the morbidity that's associated with it, and therefore it must be avoided at all costs. Chris told us that most strokes are peri-procedural, But even if the stroke occurs on day 1 or day 2 post-procedure, they could have had their actual, their impact or their original nidus during or around the time of the procedure itself, as the neurology can evolve. Despite having multiple risk factors for stroke and understanding the patients who are at higher risk of stroke, it remains unpredictable. And despite having meta-analyses of more than 100,000 patients, we still cannot predict who's going to have a stroke or not. And as one of our contributors has said, if embolic protection reduces the risk of stroke, then it may well come down to an all or nothing approach. You protect everybody or you protect none. We've heard that procedural optimizations are very important, such as heparinization, using the CT scan to choose your device, choose your vascular access, and consider carefully the anticoagulation strategy prior to, during, and after the procedure. And we've also heard that the role of cerebral embolic protection may reduce stroke. We have a very clear biologic plausibility. We have MRI evidence that suggests that it reduces new lesion volume. And indeed, we have randomized and observational data that are suggestive of stroke reduction. But we're going to have to wait until 2024, until the BHF Protect TAVI study will clarify that for us. And all of this, of course, is with the Sentinel embolic protection devices. Whether other devices can have a more relevant impact remains to be seen. So from Paris, I want to thank you for joining us for this PCR webinar. I'd like to thank Chris and Raj for their expertise and their time, the team here in Paris, and of course Boston Scientific for kindly supporting this webinar. We wish you a very good evening and a good night.